cancers. So anyone can join now.
Anyone can join. Unaona hii record na ina record. So you should use mute.
On the rise in Kenya, and they're actually increasing to a point where it's becoming sort of like an epidemic at the rate at which we are having cancers. And that's why we've been talking a lot about the different cancers and trying to see how best do we screen for them, how best do we manage them. And today we will be having Dr. Michael Mwachiro, who will take us through this presentation. And I'll be moderating the session for today. Thank you all for joining. Just a few housekeeping issues. I believe by now issues of CPD have been sorted, but if you have any issues that you'd like us to be aware of, kindly email us at knetcpd@gmail.com. I'd like to give Dr. Michael Mwachiro the opportunity to introduce himself and begin the presentation. Thank you.
Okay, good afternoon, everyone. I hope you can hear me well. It's a pleasure to join you for this ongoing discussion that we've been having on cancer, especially in our country. Let me request, could you enable me to share screen?
You should be able to share your screen from your end. Thank you.
Let me know if you can see that.
Yes, we can see your screen.
Okay, perfect. Thank you. Yeah, so my name is Mike Mwachiro. I'm a surgeon here at Tenek Hospital, and also on the unit. So it's a pleasure to join you all for this discussion. I'll be sharing briefly about early detection and screening of GI cancers in Kenya. One of the other things, sorry, so this is just a pictorial representation of the hospital, theater, and the endoscopy unit is here, and outpatient department, and the facility serves around 800,000 people in Bomet County. It's a faith-based institution, as most of you are aware, and we've been able to offer both diagnostic and therapeutic services across the various disciplines. I'm also a member of the African Esophageal Cancer Consortium. This group came together initially as research, and as you can see on the map, it spans along what we call the esophageal cancer belt of Africa. This goes all the way from Ethiopia down to South Africa. In the recent 2 years, we've also added Mozambique, Rwanda, some sites in Uganda, and it's actually mutated from what it was before, because initially all of these sites were purely research sites, and now we do both clinical care. So we have an arm for treatment, there's an arm for advocacy, and then there's an arm for research. So moving on to the main discussion, this graph is actually from the GlobalCan data from this year. And as you can see, the overall pattern has not changed for Kenya as a country. Breast and cervical cancer are still at the top, but you have prostate, esophagus, and colorectal cancer following each other. And if you look at the age standardized rates, this is globally, and this looks at the Kenyan data, you can still see the same thing. But what I wanted to highlight was that if you look at, let's say, breast and even prostate, actually breast and cervix are good examples. The incidence, so the new cancers that we are catching compared to the mortality, there's actually, the mortality bar is much less. But if you look at esophagus, so that is 12.7 age standard rate per 100,000 compared to 12.0 on the mortality side. And look at colon, 10 to 7. And then down here you have stomach, 7.6 to 6.6, and ovarian. So these cancers, the new cases we are catching and the numbers that are dying are almost equivalent. And as we've discussed over the years, that has raised some questions for us as a country. What do we need to do to be able to improve these numbers? if you look at the male-female distribution, in the males, really prostate and then esophagus and colon, and in the females, breast and cervix, and then esophagus and colon. So mainly in females, it's really breast and cervical cancer, whereas in men, prostate is at the top, but you still have esophagus and colon. So these cancers are important enough for us to have this discussion. So I looked back at the two cancers. So the main ones we have in Kenya is esophagus and colorectal. And there's been a lot of publications that have come out over the years. The main sites, there's been a case control that was finished recently at MTRH, and they actually put out quite a number of papers. There's been some historical papers that were put out in the early 90s, early 2000s, and as we've come into this current decade, there's also been more papers added to that. And if you look at colorectal cancer, these are some of the ones that I could find from the early descriptions by Prof. Saidi, late Prof. Saidi. And then there's a recent one I found from Aga Khan. And then there's a couple of papers from Tenwek, and I also saw there's a few from KNH. All of them actually highlight the same thing. We are getting late diagnosis of tumors, and we're also seeing, interestingly, in Kenya, younger patients presenting. And they also highlight the issue of gaps in treatment, and the fact that as we catch these patients, the goal would be to increase the numbers that we catch at an earlier stage. Now, if you look at risk factor studies, this was for esophageal cancer. As I had mentioned, there's been some work done by a number of sites. The first three papers here from MTRH, Diana Menya and her team looked at the interesting associations between fluorosis, oral health, and esophageal cancer. They also put out some data on hot beverages to add the discussion with actually what they found increased odds ratios for this cancer. And then this last one on traditional and commercial alcohols and esophageal cancer. We've published here at Tenwek a number of papers, one on serum selenium as a risk factor. We also looked at the T temperature, and we've been looking recently at polycyclic aromatic hydrocarbons as a contributor towards esophageal cancer. And our case control is also completed, and we are looking at analyzing this data. When you switch gears to treatment, the same thing. One of the early papers that I found was by Prof. Ogendo. He was looking at patients in KNH, post-esophagectomy. And over time, there have been a number of publications on the different aspects. So we've done some work on palliation of stenting, palliation of esophageal cancer using stents, and we did quite a bit of papers on that. And then recently, there's been some initial publications on esophagectomy and outcomes, and currently that's what we are working on. And then there's been some reviews. The one at the bottom in the International Journal of Cancer is a recent one, end of last year, that was looking at optimal management of this cancer in Africa. So as you can see, there's been work done in the different aspects of this particular cancer, both for esophageal and for colorectal cancer. And then the other bit that I wanted to highlight, just building on what has been done, has been in the last 2.5 years, a lot of work went into developing the cancer screening guidelines. And this was spearheaded by the Ministry of Health, the National Cancer Control Program, and the National Cancer Institute of Kenya. And really, this put together the key players in the cancer space and looked at how can we focus on the cancers that are screenable, and what recommendations would you want to put out as a country. And this was actually officially launched. I've put just a screenshot here of, like, for colorectal cancer, there's one of the pages which talks about this, and it was risk stratified by categories. And the key thing was that based on current data that had just come out, this was a landmark paper that had been published by the American Society of Gastrointestinal Endoscopy, which showed that patients who are, we should start screening earlier for the African population. And so even for us as a country, this was the adoption. But then if you look at this, you see we are working with a risk stratified approach for average risk, increased risk, and then high risk. And so if you look at average risk, the main thing was that to start this, patients who are more than 45, asymptomatic, no family history, and this screening should be initiated from that particular age. Colonoscopy offered if every 10 years, if the initial one is normal. Patients should have actually a fecal, an FIT test, immunochemistry test, or an FOBT test, depending on where you are. And part of the discussion around this was because of the availability of the FIT test at that time. But I think now the FIT test is available everywhere. So this really is what we encourage everyone to get. And then for places where they only have sigmoidoscopy, to be done at a closer interval. For patients at increased risk, there are two main categories. So if you have one relative in a patient who's less than 50, or an advanced adenoma in one first-degree relative diagnosed at less than 50, then you get 10-year colonoscopy procedures from age 40, or 10 years earlier from the youngest relative who is diagnosed with cancer, whichever comes earlier. And then if you look at persons with multiple first-degree relatives, or other relatives with colorectal cancer with CRC diagnosed at 50 years and older, then you have 5-year colonoscopy from 50 years of age, or 10 years earlier than the youngest relative diagnosed with CRC, whichever comes earlier. The high-risk category, that was pretty straightforward because these were the genetic conditions like familial adenomatous polyposis. If you have non-hereditary polyposis and inflammatory bowel disease, and these ones go through genetic counseling and then colonoscopy, which happens much earlier depending on which band you fit in. The other discussion that we had was that we needed to look at esophageal cancer as an important cancer in Kenya. Remember the global Canada edition that was issued just before the 2021, esophageal cancer actually had the highest mortality in the country. And a number of countries have launched, this is mainly China, screening guidelines for high-risk areas. And so in the Far East, they've shown that if you look at areas that have higher risk for this particular cancer, and there's good papers from China to show this, that it made sense to do focused screening on high-risk areas. And so based on this, we asked the same question for Kenya. Why not do this? Because if we do not start somewhere, we will continue to catch these cancers at a later stage. And so based on the initial data that was out, the main recommendations were to screen first-degree relatives of patients, of people who have biopsy-proven esophageal cancer in their relatives. And these ones have a screening endoscopy 10 years to the index age of the first-degree relative, or at age 40, or whichever is earlier. And then if you're living in a high-risk area, so in Kenya, this would be in Bomet County, in Eldoret, North Rift area, in Meru, asymptomatic individuals living in these areas should get a one-time screening endoscopy at age 40 years. And then patients who've been treated for head and neck tumors, squamous cell carcinoma, should be screened every 10 years. And those who've had caustic acid ingestion, usually after 10 years from the injury, they have probability of transforming to cancer. So these individuals should also be surveilled. And so these were what we put in there as a screening guidelines for both of these cancers. I think the key thing to highlight is the fact that if we are able to, that whole, like in colorectal cancer, the whole sequence from adenoma to tumor is, we have a time in there, around 10 years. And so in that space, we should be able to do something to catch these cancers earlier. And that is the whole basis of doing screening. Well, shifting a little bit. So if you look at, and I'm going to use esophageal cancer as an example because we have a lot of good data on this. Now, 5-year survival in the US is around 20%, and in China, where there's good follow-up, is the same. But if you look at countries like Iran, even in Kenya, the survival drops. And the key thing is that if you show up with the image on the left and you are diagnosed, the chances of cure are very high. But if you show up, which is what we commonly see on the right, then the survival odds go down. And so because of the whole nature of dysphagia and how it shows up, by the time patients have symptoms, that is late stage presentation. And so these patients will show up with dysphagia and they're now having weight loss. At that point, we are having this difficult fight to get them good curative outcomes. With the improvement now, with the chemo radiation being available as neoadjuvant and the multidisciplinary discussions, this has actually improved. But the key thing is for tumors like esophageal cancer, where the surgery itself is a bit morbid and the outcomes based on esophagectomy are quite interesting, then it makes sense to make the effort to try and catch them this early. And this applies both for colon cancer and for esophageal cancer. So poor survival is because of late diagnosis, and therefore we need to work on early detection and treatment in our population. And there's a need to therefore think about how we can screen asymptomatic individuals in these high-risk populations. So when you think about early detection and treatment, the common question is what components would you need to make this? And whichever tumor you use, all the GI cancers, the key thing would be to get your precursor lesions. So if it is in esophageal cancer, that's the dysplasia of the esophagus or neoplasia. If it is in colorectal cancer, it will be getting the polyps at an early stage. And so you need a primary screen or a primary screening test. And then for both of these cancers, currently we are doing endoscopic localization. There's a lot of research on going into non-endoscopic things, but that isn't quite yet available. For colon cancer, you are able to also do the blood tests, which can give you a clue, and you can combine that with symptoms that you can decide who needs to get screened much earlier. And then after you do that, then the next thing is now what to do with the treatment. So you have to stage this, and then you offer the appropriate therapy depending on what stage you had found them at. Now, there's an interesting paper. This came out around 2005 by Wang et al. So Wang did a lot of the early work in China, and what they did, they had this follow-up of a decade of patients they had biopsied, and as you can clearly see, the patients who had this was esophageal cancer, dysplasia, moderate dysplasia, and then severe dysplasia, and then eventually carcinoma in situ. The relative risk goes up as you climb from mild to severe dysplasia and to carcinoma in situ. So it makes sense to focus on this group because as you get dysplasia, the risk of transforming to carcinoma is much higher. And this was part of the push towards doing this screening for patients, because if you catch the precursor lesions, then you have a good chance of treating them. There was a lot of work done into what type of screening tool would best be used. And there was a lot of studies that were done. These were the early papers by Roth et al., Dorsey et al., Pan et al., and they looked at different, you can see all these balloons they're experimenting with. They all had a common theme. The sensitivity was low, even though in some cases the specificity was high. So the test by itself was not very good. In Kenya, we did a similar study around that time, and we found, we tried a number of these balloons, the same thing. The sensitivity was 52%, and then the dysplasia was equally as low. But one of the things that happened around that time was then the question of, was there other methods that they could use, because this that they had at that time seemed to be insufficient. And then there was blind sampling of smaller lesions. The evaluations was poor because of the small percentage of the cell sample. So Lugol's chromoendoscopy then came onto the scene. And there were some really good papers that showed that Lugol's iodine, just like we do for cervical cancer now, if you stain the esophagus, the areas that have dysplasia do not take up the Lugol's. The areas that are normal, they are stained. This staining is reversible. So the glycogen, which is abundant in normal superficial squamous cells, but is absent in rapidly dividing cells, takes this up. And therefore, the normal epithelium stains brown, and the dysplastic areas are unstained. And the sensitivity, as you can see, was actually very good for high-grade dysplasia of around 95%. And so here at Tenwek, we actually are able to make it up. If you get the ingredients, you just need iodine and the potassium iodide, you mix them up, and you therefore have fresh formula that you're able to use. Now there's formulations you can buy in Nairobi, and you can do this. So it's available. The beauty of this is that it's cheap. And so based on this, you're able to now pick up these lesions. And once you pick them up, the next thing, as I mentioned, is how do you treat them? And for esophageal cancer, dysplasia, you can either do excisional methods or you can do ablation techniques. So this is endoscopic mucosal resection, multi-band mucosectomy, which means you fire the bands and then you dissect those portions one by one, and that is the defect that is left, or endoscopic submucosal dissection, for which you actually get good deep tissues. The ablative methods include argon plasma coagulation and radiofrequency ablation. And the advantage is if you have areas that are circumferential and are long portions, then the RFA is able to ablate larger portions and have fewer post-treatment complications as opposed to the resectable techniques. However, the key difference is if you do ablation, then you don't have something to give your pathologist. But if you do resection techniques, then you actually have a specimen that you can send to your pathologist, and they can tell you the depth of involvement. So based on this, one of the questions we asked, and I'd like to share this experience so that we can use it as a good baseline to discuss about the practicability of doing this as a country, because we had been seeing in Tenwek a lot of advanced disease. We put in a lot of stents, around 400 to 300 per year. And many of the patients who came in were not resectable. Most of our early data was showing 90% unresectable and a very small percent that was resectable. And even the ones who are resectable were not patients, they were either T2, T3 at the time they were coming in for their surgery. So one of the questions we asked was, what if we looked at the dysplasia rate in this area, because we were in a high risk area? So we put together this study. Actually, we did it in collaboration with the University of Nairobi, the National Cancer Institute, Mayo Clinic, and Aortic, which provided the funding. And what we did was that we were hypothesizing that, as I've mentioned, squamous dysplasia is common and it's a precursor lesion, and therefore if we screen for this, we'll be able to get a rate and capture individuals who could be treated earlier. And so we went out into the village around here. This was door-to-door, meeting with the chiefs, explained what we wanted to do, invited people who are essentially asymptomatic, and then they came in for an endoscopy procedure. We stained them with Lugol's, and then we biopsied the unstained areas. And then we did a lot of analysis on the different risk factors that we thought were important. This was the inclusion criteria. You had to be from this zone. And we actually looked at the entire age spectrum. So we excluded by decade from 20 to 79, and then anyone who had symptoms or had some significant medical disorder. This is just a schema of what would happen. There were all these meetings to prepare, and then the community level approvals, and then they came in for their procedures, as I've mentioned, under questionnaire. And as you can see, we divided this BOMET into 3 zones. This was interesting. Zone A, Zone B, and Zone C were based on both climate and agricultural activities. So this Zone B is near the Masai Mara. It's much drier. This is a very fertile area, and this was a mixed zone. And this actually turned out to be important later on when we looked at our results. Here is just a team, the endoscopy procedures, orientation of the biopsy samples. And this is the team at University of Nairobi, Prof. Gidanga and Wairimu, and then the team from the US that was providing endoscopic and pathologic support. So this picture here shows what we have actually been seeing, and we continue to do this even now. This is a normal asymptomatic patient with no lesions. This is a patient with one area of dysplasia. And then here you see more linear patches. And then we had quite a number who had this mixed mosaic pattern, which was very tiny and stained lesions. And these were the ones that are a little bit more concerning. And as you can see, this you would probably offer resection, but for this one and this one, you would either choose between doing ablation or resection. The results in brief is that the majority of the patients were young, despite us stratifying by age. The average age was 46. We looked at education, alcohol smokers, family history, And then if you look at our results, the dysplasia rate, and the one that was really important was this portion, high-grade dysplasia, where you combine moderate and severe of 2.9, and then overall dysplasia was around 14%, 14.4%. And then if you looked at the multivariate analysis, we found that age was important, the location was important, and if you took alcohol, that was important. Family history and tobacco smoking, interestingly, did not give us significant p-values. And then if you look at this by age and gender, we found that the older you are, which the data even in other places supports, then you had more chances of getting dysplasia. So you can see the bands 50 to 59 and more than 60 had more dysplasia. And then if you look at odds ratios, so this was the locations compared to zone C, then the odds ratios 2.6, 2.5, and then for alcohol drinking 2.7, 2.35. And so it was pretty clear that there was something about living in those areas that made them to be at a higher odds of having dysplasia. So now putting our results into perspective, in China, where a third of the world lives, if you have 30% dysplasia and 15% high-grade dysplasia, and compare that to Kenya, where we found 14% total and 3% high-grade dysplasia, it means for every 100 people, we will only capture 3. Whereas for China, where there's a lot of people, the dysplasia rate compared to the population was actually a significant catch. And so it was very clear that in areas where we didn't have as much prevalence, then screening was going to be a challenge because of cost. So for this technique to reduce mortality, we need to find something else that can help us to further stratify significantly. And this has been the basis of the current ongoing research to be able to narrow down this pattern. And actually, we have another study we've just completed that was looking at what if you focused on relatives of patients who have esophageal cancer and looked for dysplasia in those patients as a way of screening them. Would that help? And the interesting patterns are showing is that there's some familial clustering that is going on. So we know there's still that it makes more sense to go to areas where there are high risk areas of esophageal cancer to look for dysplasia and to do early detection. So I wanted to use this example to ask the hard questions. So from inception to reality in Kenya, we've put together the screening guidelines. We also have put up our treatment guidelines. We have, and we've tested a tool for doing like for esophageal cancer. We know we can do legal endoscopy. It's affordable. We've done a lot of training. It's easy to learn once you've done a few passes, and the team can be able to catch what a dysplastic lesion looks like. For colon cancer, we also have put together the screening guidelines. We have the tool available, which is colonoscopy. But what would be the difficulties in making this a reality in our country? And so if you look at how we are set up, one of the issues that quickly stands out is that the facilities that can carry out endoscopic procedures. So for us to do this early detection bit, and I know if you did a poll of which counties are able to offer this at the county facility level, then these are few. The main procedures are being done by the private faith-based institutions across the country. And there's a number of county facilities that are doing this now well, but if you are from some counties, there might not even be those equipment available. So this is one of the questions that we need to ask, how we can be able to do that. The other thing is when this equipment breaks down, the repair costs are usually high, and the sensitivity of the cameras, the systems makes it that you really want to keep them going as long as you can. And then because of that, some places end up having equipment that is very, very old, and therefore you end up struggling to keep them functioning. And then as we've seen, sometimes we have challenges with the procedures themselves. So either partially completed examinations or the reporting system. And then the other issue of which areas offer diagnostic versus therapeutic. So for example, I get an endoscopy done in my county, but the team in my unit is not able to do therapeutic procedures. So I find a polyp, but I can't treat the polyp. And so either because we don't have the equipment or we are not trained in doing the polypectomy. So this person has to be referred to a site which does that. And of course, what happens is the sites that are able to do that have a backlog because patients are coming there. And then the other bit is public education. One of the things we have really struggled with, and I'll say this, especially like here, our endoscopy unit is fighting the stigma associated with cancer, where patients, as soon as you tell them we've seen a lesion, then they have either the fear that they will die, it will spread, or if we touch it, it will spread quickly, or if people here, they were found with cancer, maybe they will die because they saw somebody else die of the same problem, whereas that patient died because it was very advanced disease. So those are the challenges that we need to help the public with, and we as clinicians need to look at this and the different stakeholders, the nurses, the public health teams, epidemiologists. How can we all synchronize to be able to help improve public education? So spread information where it can be done, the risk factors for the different cancers, whether it is esophagus or colon or gastric, reducing the fear of the unknown and helping them to say, there's an interesting paper from China, which was saying that patients who discovered that they have these symptoms knew it was going to be cancer, but then were afraid of revealing that they had the illness because they feared what would come next. And so even in our own country, these are some of the issues we have, where relatives will tell you, don't tell the patient that you found a problem X. And then acceptance of the endoscopy procedures, where people don't really understand what goes on. And so we need to help the public so they can come forward. If we say, if you have a relative who has cancer, you need to come for screening. And then partnerships and collaborations. Cancer care is a multidisciplinary process. And so these are the tumor boards, the collaborations between hospitals, with the oncologists, with the radiologists, with the nurses, with the stoma nurses, and with the people who are able to offer support, both pre-cancer diagnosis, during the treatment, and then after they go home. Because remember, the journey on the patient side is actually quite interesting if you think about it emotionally, what they're going through, processing all this information, trying to figure out where they need to go for this kind of treatment. So there's room for us to work on those partnerships. And I can even put here, in Africa, one of the ways would be either looking at a regional center model where regions aggregate and, like for those in Central or South Rift or North Rift, they work as an axis and are able to share the resources that they have and the expertise. And then there's the issue of endoscopy training. So for us to improve this problem, the different components are there, but one of the key things is having personnel to be able to do these procedures, the nurses to spend time with the patients. If you look at the endoscopy side, it means each county having enough gastroenterologists or surgeons or family physicians who are able to do the diagnostic bit. And so this would be a mix of short-term versus longer training. So for short-term, it's people who are already the specialists who want to add that on. And then for longer trainings would be for advanced procedures, like to learn how to do mucosectomy, so that you're able to offer that at multiple places in the country. I think as is happening now, this really is the way forward, having this as part of the specialty training so that all surgeons who come out, gastroenterologists who come out, learn both the diagnostic and some of the relatively simple interventional things. And then as a country looking at having advanced endoscopic training so that we're able to offer this to our personnel in the country. And I think we just published a paper here at TENWIC that was looking at gastrointestinal endoscopic training amongst surgery residents who've been going through the 5-year training and following them up. And it was interesting to see the level of proficiency improve, but also the level of care that a graduating specialist is able to offer once they move out. And this, if you track those specialists to the zones they have gone, has really made an impact even in our current medical and surgical ecosystem. And then another key thing is integrating with primary healthcare. So because this is where the majority of the interactions happen before the patients are moved on. So I think whenever we are thinking about setting up primary healthcare as a country, cancer care and this particular screening and early detection bits need to be synergized. And I know this is going on. I'm just putting this here as a point for us to discuss. And then the referral systems, so that we reduce the gaps between once we pick up something on, if we detect it early, that we make sure the patient goes on to the next level of care that is needed. Now, an important discussion is the cost. A review from both actually China and Japan showed clearly that for the success that they had with the screening programs, the biggest challenge they had to navigate was the cost. And for many systems where screening is being done, the system has to be centrally funded, either so that you are able to do this in mass. One of the discussions we've had a few times is the role of NHIF in providing this, given that we can't say to pay for everyone's endoscopy, but right now NHIF doesn't pay for endoscopy or colonoscopy procedures. What if we asked for the focus to be on the high-risk areas, or if somebody has a patient who's confirmed to have tumor and therefore meets the criteria of undergoing screening, then NHIF says we can pay for that role. And for this, we need to work together to lobby with the different groups to be able to implement this. But this whole issue of cost and making this screening program work because of the different bits that are needed, the equipment, the personnel, and the cost of care is going to be a significant one. And then after you find these lesions, what do you do? So as I showed, for us, we scoped all these 300 patients. We found 14% who had dysplasia. We brought them in for follow-up endoscopies. Some of them got mucosal resections. A number got both mucosal resections and radiofrequency ablation. And I think we had a number who actually got complete resection of the dysplasia. One patient out of these, actually, we found cancer and was routed into the pathway for surgical treatment and it turned out to be carcinoma in situ, which progressed on the next follow-ups and they got treated. So if we are going to be running this early detection activities, then we need to be prepared to treat the people that will be found. And so this goes back to the issue I was raising about having regional centers that can now focus on providing the different personnel and equipment needed to offer this. So as I conclude, and then maybe you can have a discussion, what are the next steps for us as a country? Are screening programs possible in Kenya? So you need to go to places that are have high rates of either esophageal cancer or colorectal cancer. Then the questions you ask yourself is there a male-female predisposition or predilection? And then there would need to be community buy-in so that the people know that there's trust in the process and there's mutual respect, that they're able to come in for the screening knowing that we'll find something and we will do something about it. And I can say from the many visits we had out in the community, this issue always came up. The stories about somebody who'd been diagnosed and passed away because of some other issue lingers on, and helping to demystify those reasons so that people see that we really want to improve their outcomes and to have better, to have cure. And then having a committed team of endoscopists, pathologists, community workers, radiologists. This is going to be a team sport. For esophageal cancer, you need to have good quality endoscopy with Lugos. For colorectal cancer, the same thing, good quality endoscopy. And then all these bits here refer to pathology, biopsy orientation, good quality pathology, and then data management. The success of the program in China has been because they've kept a registry that has spanned over 3 decades now. And they've been able to track the villages that they did the initial randomizations and follow these patients up, and actually to show that one-time screening has been able to have very good outcomes in terms of reduction in mortality or improvement in survival. And then ability to locate and recall patients, ability to refer patients for therapy that is needed, and then multiple sites carrying out endoscopic procedures. And then what I have down here in bold, if we find a good and endoscopic primary screening test for each of these cancers, like for esophageal cancer, that would be the holy grail, because it would mean that the patients would not have to undergo an endoscopy procedure, which needs a skilled person, the equipment, going to a place that can offer this type of care. So there's a lot of research going on currently with the breath tests, use of sponges, capsules, and this would be, and blood tests. And this would be interesting to see in the next 1 or 2 years when some of this data becomes available, that we can switch to an endoscopic screening test. So thank you very much. I would like to stop there so that maybe we can have a discussion, but really I just wanted to stimulate this discussion about early detection, not just in Kenya, but even in the African region, and what we can be able to do to improve outcomes for GI cancers, esophageal, colorectal, and gastric cancer. Thank you.
Thank you very much, Dr. Mwachiro. I think this is a really, really good presentation that has been done. And I like the way you've transitioned from what is known and then what you've researched on new knowledge and back up with now research, and then after that, the interventions that you've done. And I think this is a way that we should be training all healthcare workers right now in terms of all the problems that are existent in Kenya. So what is known, and then bridge the no-do gap. I think that's where we fail as healthcare workers and medics in the profession. And I think this is a really good presentation. There's a question here on issues of colorectal cancer. So how do you distinguish when to start screening for colorectal cancer? This particular person is saying that they had a patient who was treated severally for hemorrhoids on and on and on, and it's something that happens in the counties. And even in national referral hospitals, people are treated for hemorrhoids and then it ends up being colorectal cancer. So at what point do you know if a patient presents with hemorrhoids, probably you should screen for something else?
Thank you, Nancy. That's actually a very good question, because this is what we need to talk about as the society. Now there are some symptoms and signs which, if you have, really that should be a flag for you to have additional treatment. I mean, screening or investigation done. And one of them is anytime you see blood in stool, that by itself is a flag which needs to be investigated. So I would ask that for patients who have things like blood in stool, that they need to have the colonoscopy procedures done. Secondly, if you've been seen in multiple places and different people keep saying maybe this is hemorrhoid, but the constellation of symptoms. So if you see you have weight loss, or if you have family history, when those things happen together, I think the best thing we should encourage is that patients need to have, one, be referred to a physician, a gastroenterologist, and two, that they should have their screening procedure done so that they will be able to be assisted with an earlier diagnosis. Many of the delays in care is because of patients who had gaps because they were being seen and treated for, like in esophageal cancer, reflux, and in colon cancer, it was labeled as hemorrhoids. So any patient with those symptoms, really, you should have a colonoscopy as soon as possible. And it might turn out to be negative and it's hemorrhoids, and then you are appropriately referred to the surgical team for treatment. So thank you. I agree. That is a really, really key question.
Thank you very much for that. There's a question from Gilbert Makoha on gender distribution. So they're interested to know the gender distribution with regards to esophageal cancer.
Thank you. So if you look at the global data, so if you put all the patients together, then you see that the male to female ratio is slightly skewed. There are more males than females. But if you look at more regional data, so like what we've seen from our data here at Stenwek, and the data in the Rift, we've actually found that there was a male to female almost 1-to-1 ratio. And so I think here in Kenya, I would say that women are equally at risk to get this as far as men. I mean, men and women can get this equally as much, but the global data shows a slight, a leaning towards males more than females for esophageal cancer. Thank you for that question.
Thank you very much for that. There's a question here from Professor Bat. The question is, would you comment on Barrett's esophagus and the role of diet in colon cancer?
Okay, thank you. So just to go back, there's some details put in this slide, and thank you for that. For Barrett's esophagus, so we see mainly esophageal squamous cell carcinoma in this part of the world. We see a few patients with adenocarcinoma, which is the other variant, but predominantly we've been seeing more squamous cell. Over the last few years, we've had more adenocarcinomas begin to show up, and we think it's a reflection of change in lifestyle. And there are a few people who postulate that it really is a gastric origin tumor. So Barrett's esophagus is essentially the precancerous lesion for adenocarcinoma, the way neoplasia or dysplasia is for squamous cell carcinoma. And the key thing that has been linked with this, especially in Europe and in the Americas, where they see this type of variant, has been the component of reflux and having exposure at that squamocolumnar junction. And then you have transformation of the cells from the normal type to the abnormal dysplastic metaplasia, which is now the Barrett's. And if this is not treated, will lead to cancer. And then the other question you had asked was colorectal cancer and?
The question was on the role of diet on colon cancer.
Yes. So for colon cancer, we usually have a number of things that we consider as, we actually list them as modifiable risk factors. And what that means is there are things that we can remove or change and alter. And so diet, there are a number of things in diet that fit here. One of them is what has been shown, intake of red meat, intake of processed meats. If you have people who have low fiber diet, and then those who have high fiber diets, those who are, I call it averse to vegetables. So people who have low vegetable intake. And then I don't know if some people here consider alcohol as food. Alcohol intake has been also listed as one of the things that is a risk factor. So the few ones that I've mentioned are the things that at a personal level you're able to control. You can decide to change how much red and processed meats that you take, thereby reducing your risk to colorectal cancer. And of course, just since we're talking about this, the other modifiable risk factors which you can change. So diet is one of them. Another one is things like obesity. So in general, if you're able to keep your BMI within that normal range, that is much better. And then we've also seen physical inactivity being connected with colorectal cancer. And then there are those things which are non-modifiable, what I talked about, the inflammatory bowel diseases, the family history, the genetic syndromes, and then age, because you can't change your age. Once you're more than 45, you move into that band. But the things like alcohol, tobacco, those ones you can change, and then the diet issues that you just. Thank you.
Thank you very much for that response. There's a question here from Tabitha Afula on how do we create awareness about early detection of these cancers, because early detection is very key, and we need to engage the public, because a lot of the engagement seems to be happening around healthcare workers, but how do we communicate and engage the public so that we ensure that people don't die from cancer, yet it can be diagnosed early and managed early?
Thank you. I think I will share from our experience here and what we have done to help with awareness is, one, to make use of the local radio and TV stations. We've done a number of recordings on this particular, the cancers that we see commonly here. And we've talked about, the risk factors, what you need to worry about, the signs and symptoms, who needs to come for an early endoscopy procedure. And so that was really helpful in getting the information out to the public. I think if we look at it from a country point of view, this is where I call them public-private partnerships, like people of the fourth estate, we can partner with. We can make use of things like the social media now, because now everyone is either on Facebook or Twitter or LinkedIn, and you can share information on those platforms in a simplified pattern so that people can understand these cancers. I think a question I've been asked often is, how do we simplify this information into bite-sized pieces that the public can also understand? Like if we said first degree relative, what does that mean for us in Africa? Because here in our clinic, if you tell them it needs to be your first degree relative, you actually have to specify, because people say this is my dad when they mean your dad's brother's cousin, which in Africa, they're still my dad, but they are not your primary degree, you're not first degree relative. So those kinds of information, so that we can help them to know. But I think it would be synergizing on the platforms that we have to share this information. And this can be for the different cancers, colon, GI, liver, lung. We can actually share this information on the networks that we have. And I'm very grateful to some of the TV stations that reached out to us and said, we would like, there've been so many questions, we want to do a series on cancers, and we were able to do that. Yeah, thank you.
Thank you so much, Daktari. There's still more questions coming along. There's a question from Dr. Masabi. Are there any reliable serum tumor markers for cancer of the esophagus that can be valuable for screening?
At the moment, no. And I'm sorry, I may not know this off the top of my head. I know the current blood, so we call this tissue blood biopsies, have been looking at methylated RNA as a marker of either. So there's some studies going on in looking at the tissue RNA that is in the blood. So you can get a blood sample and look at that and see if that will have correlation with esophageal cancer. I think the question we are all asking is, if we did find such a thing, then it will make a difference, because you would just get a blood stick and get that. So I will list that down as something to follow up on. But off the top of my head, no. I would not say I know of one right now.
Thank you very much for that. I think one of the things I should let you know, Daktari, is that there are a lot of comments on how the presentation is really good, and people asking for your slides and your contacts. So if if it's okay with you, you can share with us your slides and we'll be able to share that with the team.
Okay.
There's a question.
Yeah, go ahead.
There's a question here from Moses Ngibwini, who wants to understand, is there a relationship between oral health and GI cancers?
Yeah, thank you. That's a great question. And actually, there's a lot of interesting research that is going on currently, looking at what we call the oral microbiome. And the whole idea is that if you have these cancers, because of esophageal cancer, you get dysphagia and there's stasis. It changes the microflora in your esophagus and in your mouth. And therefore, if you test for certain microbiomes, you are able to find an association between that and esophageal cancer. The other interesting paper, and this was done actually by one of our very own Kenyans, Anna Menya from MTRH, as part of their case control study, they looked at fluorosis and oral health. So fluorosis, if you live in places, and off the top of my head, I always remember Nakuru, there are some places where there's a high fluoride content in the water. And when you drink the water, it stains your teeth and they have this discolored teeth. And so there was this hypothesis that patients who have exposure to fluorosis then might have an increased risk for esophageal cancer. So the guys at MTRH did this study, and it was over 4 years, where they looked at patients who had cancer and patients who did not have cancer. So it was a case control study. And in that process, they looked at different risk factors, some of them which I've mentioned, and one of tobacco, alcohol, education levels. But one key thing was oral hygiene. And they also looked at missing and decayed teeth. And it was interesting what they found, that there were some patients who had esophageal cancer, and I think out of the numbers that they had, and this around 400 had poorer oral health compared to the controls. And then they looked at this issue of fluorosis. So if you look at patients who had no fluorosis versus those who had either moderate to severe fluorosis, the people with moderate to severe fluorosis, there was around 44% of these, and they had odds ratios of around 20. What that means, and then they did some fancy statistical work to adjust for this. And they found that if you had mild fluorosis, you were also at risk. So the bottom line of their study was, if you had some oral changes like, this thing that causes the mouth, leukoplakia, if you have tooth loss, and if you have decay, this increased if they had severe fluorosis, and it also increased the cancer risk for esophageal cancer. So the study showed that there was increased odds. So it means the number of times you are able to get a particular problem for those patients who had these problems with fluorosis of the mouth. And I think they also looked at things like groundwater, fluoride levels and things like this. But the key thing was that in these areas that we need to do some work to look into these oral health issues, but there's clearly an association. And right now, the ongoing studies across, like in our consortium in the different countries, is this whole question of the oral microbiome and what that will show. But clearly the initial data is showing this association. So thank you for that question. I think it's one of the fascinating things that we were able to find when they did this investigation into the oral health issue.
Thank you, Daktari, for that. I know you touched a bit on the role of like first relatives, who then present, like your relatives are the ones, if your relatives have like colon cancer, then you're presented at high risk. So this is a question, I'll keep the name anonymous, who say that their mom and niece died of colon cancer. And so is there any cause of worry for them, even though they do not have any symptoms? And what measures should they take?
Thank you. That's a really good question, and I think if we can spend some time talking about that, it will also help a lot. As I mentioned, if you have a confirmed relative with colorectal cancer, then you are risk stratified into a higher band, and therefore you would need to be screened, because we've seen that having a relative with colorectal cancer is a clear risk factor for a subsequent relative getting that particular cancer. I would say for us here at the clinic, what we do is any patient who comes in and we get a diagnosis of colorectal cancer, esophageal cancer, we actually offer them at the same time that they're there to be scheduled for a screening procedure at the time of their choice. Either they can get a colonoscopy or they can start by doing the other tests that we talked about. So I think we really need to emphasize this message that if you have a relative in your family who's either your mother, your father, your brother, your sister, your daughter, or your son who gets this any of these cancers, that you would be at a higher risk, and it would be key that you get a screening procedure done. And as you've seen, if you do this procedure and there's nothing, then you simply wait until when you're due to have another procedure done. So I think thank you for that question. That is a really, really key message that especially at the facility levels where we interact with patients and their families, part of the discussion should always have this particular issue you've raised, that as we give out the diagnosis to one family member, then we have a discussion with the rest of the family about how they can also be screened, and then just be at a higher awareness that they need to regularly follow up on that particular status that they have, because they have a patient who was confirmed to have this particular cancer. So thank you very much for that question. I would encourage you to reach out to a facility near you that has endoscopy, or a gastroenterologist, or someone that you can have a review done. And if there's nothing that is found, that's good, but at least you'll have checked. Our ultimate goal is that we are all helping each other to be able to navigate these issues. So thank you very much for that question. It is a really key issue.
Thank you very much, Daktari. And there's a comment here where from Dr. Masasabi, who's saying that we should have a proposal to have enhanced training in endoscopy as CHAS rotate in the various units, like the cardiothoracic and the gastroenterology units. And this might help in combating the rise in GI cancers. And I really, really agree when it comes to that. There's a question here from Dr. Njuki, who would like to know what's the age of the youngest person like you've attended to diagnosed with colorectal cancer or the esophageal cancers?
So for esophageal cancer, it's actually like 9 years. For colorectal cancer, I wouldn't know for the whole country. I think for our unit, we've seen 16-year-olds, 14, 15-year-olds with this particular cancer. The striking thing about the patient who had esophageal cancer was that it was a family. So we had a mother, daughter, and child, one family. And they presented to us a different, I think it was within the same, it was striking because we saw them within either a calendar year or like a year or two from each other. and they all had advanced disease, and it was very aggressive. So we know, I know somebody had asked, does it mean that cancer is genetic? There's a very strong, like for esophageal cancer and colorectal cancer, there's a very strong genetic predilection that is happening. And one of the things we are doing because of that particular issue is looking at a combined genetic analysis as part of the consortium. You know, we want to have this nice pooled analysis of data from across the region that will help us to answer this particular question. But without a doubt, there's a very strong linkage across those generations.
Thank you very much for that. There's a question from Jesse Githaiga, which is a follow-up of the question that you've answered. In terms of what's the, in Kenya, like where the prevalence of GI cancers, where is it more prevalent, where like is it at risk at the most? Maybe you could elaborate. He particularly is interested in northeastern region, whether that is also like a high risk area.
Yes, thank you. I think I saw that question or comment at some point, and that is, you are right. So we are seeing a lot of, and this is registry data from Dr. Korir and her team who've been at Cambridge, then now that the NCI is working on this, that there were hotspots in the country. And if you look at the map, the main regions were North Rift, South Rift, and then we have focus in the east, in the west, that's Western Kenya, Nyanza. And then there's another focus for esophageal cancer in the Meru, northeastern region. The interesting question, of course, as an epidemiologist, is if these areas are geographically separated like this, what is the common thread? Because the people groups are different. Like, you know, in the western area, it's Luos, Luyas. In the Rift Valley, it's the Kalenjin mainly. And then in the northeastern, it depends which part. There's some reports from Meru, and then the people who live in the northeastern area. And then there has actually been a number of referrals, like we've seen from the coast, Kilifi, Kwale area. So those are the current hotspots. The question we are all asking now is what risk factor is tying them together? And you can actually ask the same for this whole belt, the East African belt, you know, Malawi, Tanzania, Mozambique, South Africa. We have different diets, different lifestyles, but what is tying us together? And for me, I always call it the elephant in the room. Part of it is the things we've talked about, smoke exposure, alcohol, tobacco, genetics, and then there are some dietary issues that come into place. But I would say those are the zones that in Kenya would think about for esophageal cancer. For colorectal cancer, it's a bit more widespread. It's not in pockets like I've mentioned for esophageal cancer. Yep, thank you.
Thank you very much for that. And I think that elaborates a lot. So we're almost coming to the end of the presentation. A few more questions, Daktari. There's a lot of, like there's a resurgence of H. pylori infection within our community. And how would this now affect development of GI cancer? Are we expected to see a rise because of that? Or this is just something that is passing?
That's a good question. I'm trying to figure out the best way to answer it. I think without being speculative, what is clearly shown is that H. pylori is associated with development of gastric cancer. That much the data has shown that. What is being investigated is the role of H. pylori in things like esophageal cancer, where that role has not been shown to be as strong the way it is for gastric cancer. I think the question about increasing H. pylori in the community, I always wonder, because sometimes our patients labeled as H. pylori having H. pylori because they just presented with some symptoms? Some people label that as having H. pylori, or were these actually confirmed, biopsy proven or tested H. pylori? So I would say it would be hard for us to speculate that with the increase in the H. pylori reports that there would be an increase in gastric cancer. But what I can clearly say is that the data is clear that the H. pylori has been shown to be a risk factor for gastric cancer. And there's a number of people who this is what they do. They just study this particular project. There's some ongoing work that is collaborative. It's a global collaborative research work on just H. pylori strains, and whether there are different types, and how that plays into gastric cancer rates across the different regions of the world, and where there's commonalities. So I would say, I think take-home message is the data clearly shows H. pylori is important, but I don't think we can say right now that because there's an increased reports that we should have increased reports of gastric cancer in our population. Yeah, thank you.
Thank you very much for that answer. And I think we've really answered a lot of the questions through your presentation and through this question and answer discussion. Maybe I'll give you an opportunity to give a parting shot to the attendees.
Mm-hmm. Yeah, thank you. Thank you so much for allowing us to have this discussion. I think the key thing for us to highlight as we finish is, one, that cancer is curable if caught early. Secondly, that I think we all have a role to play for us who are clinicians in the care, the dissemination of information, for those who are patients or caregivers in helping to spread awareness and to do the bit that is required to ensure that if we see the symptoms, that we go early for early detection techniques, having endoscopy procedure, having an FIT test done. If you fit into any of the categories that we have done, and then you should, you're encouraging people to reach out and have screening tests done. And I think above all that we should leverage on the connections and collaborations that we have to be able to continue fighting these GI cancers as a country. And then the parting shot, of course, to the ministry and the stakeholders who we need to collaborate on setting up screening programs in this country will be an interesting undertaking. And I think that is the next thing that we need to focus our efforts on, building the capacity, training, having the endoscopy equipment, equipping our county facilities. And there's a lot of work. So as I finish, I'll say thank you, and let's all continue doing our bit to help improve outcomes for this country. Thank you.
Thank you very much. And I think there's an echo from everyone who's attended the session that this is a really, really good opportunity and a good session that we've had. And I think the word is out there, so I won't dilute what Dr. has said. Again, if you have any issues with CPD points, kindly email us at knhcpd@gmail.com. Otherwise, please do have a good afternoon and enjoy the rest of your evening. Thank you.
Thank you. Bye-bye.